Okay, welcome back, clinical problem solvers. I'm so excited today. We have another rheumatology VMR, and today one of our discussants with me is Andrew Sanchez, and we had previously discussed a case that was presented by Dr. Gupta last time. It was a really exciting case, so I'm excited to see this time what the case is going to be as well. So I'm going to start with some introductions. For those of you who don't know me, I'm Jeffrey. I'm one of the rheumatologists at Duke. I have a specific clinical interest in clinical reasoning with a specific focus in sarcoidosis and specifically also neurological involvement of rheumatologic disorders. Akash, we'll go with you next.
Hi guys, Akash Gupta. I'm faculty with Jeffrey in the Department of Rheumatology at Duke. I have an interest particularly in inflammatory eye disease. I did half a residency in ophthalmology, and as well as I enjoy seeing patients with general rheumatology.
All right, Andrew.
Thanks for coming back, Akash. Akash and I are on a first name basis because we went to residency together. I'm Andrew Sanchez. I'm a hospitalist at BI. I don't know how I'm here because I'm not a rheumatologist, unlike Jeffrey and Akash, but I do really like diagnosis. I have my own diagnosis focused podcast called Diagnostic Atypia. I actually just got some of our audio onto YouTube. So for those who are tuning into the YouTube recordings, you can find us there now to listen to our episodes. It's just called Diagnostic Atypia. But yeah, very excited to hear this case.
Awesome. And then I believe Siva, do you want to introduce yourself and how you're doing?
Yeah, sure. I'm Shiva. I'm an IMG from India, currently based in Buffalo. I'm excited for the case. I'll be doing scribing today.
Okay, and then finally Jillian.
Hi, I'm Jillian. I'm a medical student in New York. I'm excited for the case, and I'm giving teaching points.
Okay, awesome. So let's begin. Nakash, why don't you give us our first aliquot?
Awesome. So I'm gonna walk through this case for you guys as kind of how it happened in time and then how it came to me. So what actually started all this journey off for this patient was abdominal pain. So that was kind of her presenting symptoms. So this is a young lady. She is, let me get you guys the age here. She's 30 years old. She has a history of obesity for which she recently started Zepbound, which we'll talk about. She has sleep apnea on CPAP. She has depression, anxiety, and she also has eczema, for which she was started recently as well on Dupixent. So her story begins, about several months ago in the summer. She was just starting Zepbound and she had to go to urgent care because she had 4 days of generalized abdominal pain, nausea, vomiting. At that time, she reported her abdominal pain was in the supraumbilical aspect of the abdomen, and let me just get some of this data for you guys. Give me 1 second here. Um, so yeah, so she had this going on. She had significant diarrhea, soft stools, she described, some bright red blood per rectum. She was having weight loss, but she attributed that to being on Zepbound. So she went to urgent care, and when she went there, and I have some of the labs, guys, not everything, because this was outside of our system. But basically, she had tenderness kind of diffusely throughout when she was seen. She had a CBC CMP that was otherwise unremarkable. And sorry. And so basically, what happened was she gave a stool sample, stool studies, and she was told by urgent care, this is your Zepbound, so stop your Zepbound. Now she's going to come back to urgent care a week later, and they got her stool studies back. So they sent stool pathogens. Her Giardia, Salmonella, Campylobacter, E. coli were negative, and she got a stool O and parasites done. So she's been off Zepbound, and she had a CAT scan of her abdomen. So this was the first time they did imaging on her. And let me get you guys the read of this. So when they read her abdominal imaging, they saw multiple small retroperitoneal lymph nodes. The right common iliac lymph node was 1.1 centimeters. The right external iliac lymph node was 1.6 centimeters, and right inguinal lymph node was 1.3 centimeters. And they noted some splenomegaly for her. I'm going to stop there and see, Jeffrey or Andrew, if you guys have some questions at this point. So this is a CAT scan that was done 2 weeks from her presentation with all this, and see if you guys have questions or anything else you want to know.
Yeah, I think this is plenty to chew on for the first aliquot, Jeffrey. I forget how we did this last time, but I could maybe start on more of the general medicine things since that's kind of what we're starting with, because the patient's really coming in with kind of an acute gastrointestinal sounding syndrome. So, in terms of this comment of blaming the tirzepatide for the presentation, so when you start tirzepatide, there's this hand wavy pathophysiology where we ultimately tell patients you may experience some gastroparesis from this, so decreased gastric motility, which can cause a lot of postprandial nausea and vomiting. And the kind of peristalsis you experience during that kind of happens paroxysmally, can be painful. So people do come in with pain, but usually it's more of a kind of like a nausea, vomiting predominant syndrome. I think chronically GLP-1s can also cause some gallstone pathology. But of course, they just started it, so it'd be a little odd for them to kind of form gallstones really quickly. But no, I think kind of the first step in the evaluation of abdominal pain is really in the acute setting if someone is failing to resolve at home and coming into the hospital, you really need to get a CT scan to see what's going on because the utility of kind of identifying the quadrants where the location is really isn't that great for identifying the exact kind of anatomic site of pathology. So it's automatically like a little bit weird that someone's coming in with these symptoms for a week. And not only is the CBC normal, like oftentimes with even if it's a non-infectious etiology, just from being under stress in the body, you'll come in with like a leukocytosis that's neutrophilic. That won't be more than like 15 or so if it's reactive to whatever. So it's automatically a little weird that they don't have a leukocytosis at all. And then it sounds like the CT also didn't identify anything inflammatory in the abdomen. Like there's no diverticulitis, no ileitis. And what we're really expecting if the symptom was nausea, vomiting, like diarrhea, as in this case, we would be expecting some sort of like enteritis, colitis, or some sort of combination of those things. So we're not seeing that here. The CT scan isn't perfect for detecting all variants of colitis. I was actually just reading about this the other day. Even with
Hmm.
C. diff colitis, you can miss very mild versions of this where there just isn't a lot of bowel wall thickening or enhancement. So this patient still could very well have a very mild gastroenteritis that we're not seeing, but there's nothing like raging going on, which is corroborated by the CBC here. So I'll pass off to Jeffrey maybe for like the findings of the lymph nodes. Like, do we then blame that? Just with my only comment being, lymphadenopathy is often reactive to something. So if there is something going on in the belly, you have to consider, is that just a reaction to something else going on, or is that kind of like the primary site of pathology? But what do you think, Jeffrey?
Wow, this is a crazy presentation. I definitely didn't. So first of all, I'm not familiar at all with Zepbound, or some of the other medications, even and what possible side effects they could create. So that's always something that's on my mind. But I definitely don't expect this CT abdomen pelvis. I mean, this is like so surprising. Like, I don't know how to put together an acute, like, I guess I don't have much experience with in an acute viral or infectious gastroenteritis seeing splenomegaly. I mean, sure, maybe the small retroperitoneal lymph nodes are just reactive, but splenomegaly is very odd of a finding. And so my first thought is to say that these two things are not connected before I think that they are connected. Because if I were to put these two things together and have it be connected, I'm looking for like either a toxic or infectious process that can cause GI symptoms and cause lymphadenopathy and splenomegaly. And for whatever reason, the first thing that jumps to my mind with that picture is yersiniosis. So Yersinia
Hmm.
pseudotuberculosis, specifically that species, is known to cause mesenteric adenitis.
Hmm.
It can cause severe abdominal pain. Looks like appendicitis, or the classic story is like supposedly severe abdominal pain, diarrhea, like an illness, and then they even take out the appendix and it's normal. Um, and often they see like a mesenteric adenitis, which I guess we're not seeing here. And theoretically speaking, because there's some lymphoproliferative nature of it, maybe you can get splenomegaly. But if that's not the case here, then I would have to assume that maybe like this splenomegaly was incidentally found. Like, could it be that, for example, one of the more common causes of splenomegaly is, if there's also hepatic involvement, maybe she has portal hypertension. Maybe if we go further into the history, we'll realize that she has hepatitis C or something, and that's just incidentally found. Or maybe 3 months ago she had an EBV mononucleosis like illness, and this hasn't resolved yet. But I'm struggling to find ways to put these two together. Of course, like I wouldn't expect IBD. I wouldn't really expect rheumatologic diseases to present with an acute GI illness and splenomegaly. So that doesn't fit well with me right now. So if it is infection, which would be a really weird thing to tie the two together, your synostosis, TB can cause anything, so maybe TB, and then histoplasmosis can also cause inflammatory bowel disease-like features. But I'm struggling to fit those two together. So, gosh, I'm curious as what happens next.
Yeah, so when she was seen again in urgent care, she gave more stool samples. One of them was actually positive for cyclospora, and I don't know if I'm going to say this correctly, cayetanensis. So, and then they sent labs on this young lady. So she had a pregnancy test that was negative. They sent EBV antibodies. She was noted to have a positive IgG. It's AB slash VCA, and her AB slash eBNA was positive, but her AB slash EA IgG was negative, and her AB slash viral capsid antigen IgM was negative as well. They sent a CMV IgM, which was negative. Her ANA was positive. The titer was 1 to 640 homogeneous. They sent an LDH that was normal. HIV was normal. Acute hepatitis panel had a negative hepatitis C antibody. Hepatitis B core IgM antibody was negative. Hepatitis B surface antigen was negative. Hepatitis A IgM antibody was negative, and they sent a syphilis that was negative as well. I can stop there, tell you like just a little bit what happened when they try to treat her for the cyclospora.
Yeah, I think it's a good stopping point.
Okay.
Because I imagine, these O&Ps sometimes will pick up stuff that kind of just lives in us or that we got like a very long time ago and like never fully cleared. And usually they cause more like indolent diarrhea, not something kind of
Huh.
like acute. So I'm gonna guess she gets treated and I don't know, maybe it gets better. And this just confirms Jeffrey's suspicion that really the acute gastrointestinal syndrome actually isn't even related to kind of the reticuloendothelial system activation we're seeing in the form of lymphadenopathy and splenomegaly. So, like, are those issues even connected? Because I'm kind of with Jeffrey. I'm kind of skeptical now. I mean, base rate always wins in cases like this. This could just be like a CT negative viral gastroenteritis that gets better. And we see her in 2 weeks, and the GI symptoms are much better. Hard we'll incorporate the stool pathogen treatment into that. And then what we're left with is basically the splenomegaly and lymphadenopathy. And I feel like at that point, It's like nice that we have a lot of these tests, but I think something important to consider is we only have abdominal imaging right now. So we don't really know how diffuse this lymphadenopathy really is. Because kind of step one in interpreting lymphadenopathy is figuring out how diffuse it is. If it was only retroperitoneal, that actually is a much narrower differential diagnosis and prioritizes some things like IgG4 disease. But if it's diffuse, then a lot of these tests you sent actually do carry a lot more weight. Like things like HIV, EBV are more likely to cause a diffuse activation throughout the whole body, whereas if it was more regional, like I said, it could be something else. So I feel like next steps for me before the testing would have been, if she comes back to clinic, like what do we do next? Probably like CT chest, lymph node exam, figuring out if the inguinal and the axillary nodes are involved. And then just doing like a review of some symptoms because she's coming in for like the GI symptoms now, but has she been having like fevers, weight loss, night sweats, joint pains, rash, and then basically going to Jeffrey's rheumatologic review of symptoms past that. But that's kind of where I'm at, Jeffrey. I feel like I'm excited to see where the clinical trajectory goes in terms of does the GI stuff go away or is it part of the syndrome and then kind of characterize lymphadenopathy.
Yeah, I think I'm right there with you. I guess, I'm not that familiar with cyclosporiasis, the presentation, but my thought was that it would be kind of more of something like Giardia, where you have chronic diarrhea, and then maybe if you were had HIV AIDS, it could be more severe. Like maybe theoretically speaking, if you had AIDS, it could cause like bloody diarrhea. And maybe that, I'm not sure. Is this a false positive we're seeing there or not? I know that immunocompetent patients can definitely get it, but usually, and similar to like Giardia, but usually it can be a self-limited illness. So I guess, I'm right there with you, Andrew. I think we're gonna have to figure out, is this an incidentally found splenomegaly? We have a lot of other labs that kind of popped back positive, including a positive ANA. So of course, I imagine they're probably going to be consulting rheumatology and I will say that it's not uncommon for patients to have a positive ANA. So I think it's really important at this step to ask, is this ANA going to be helpful or is this ANA going to be confusing? Because it's going to be usually one of those two categories. And more often than not, it's the ANA is confusing. So you have to be very careful. And in what situation would the ANA here be helpful? I think if we have very specific signs or symptoms that point towards a chronic disorder that has features resembling an autoimmune disease. The primary ones that we would focus on are going to be lupus, Sjogren's, scleroderma, and myositis. So everyone has like a different approach to how do you ask a review systems about that. But I would say that generally speaking, my approach is I start with Raynaud's. And the reason I start with Raynaud's is because for if I'm looking for scleroderma first, more than 90% of cases have Raynaud's. So if they don't have Raynaud's, okay, I'm kind of almost eliminating that. It's not 100%, but I'm almost eliminating that. Then I move on to the next bucket, which is going to be looking at muscle weakness. Now, if the patient doesn't have muscle weakness, it usually means that they don't have myositis, but technically, again, there are rare cases where you can have amyopathic, what's called amyopathic myositis. So I look for those two things first. And then after that, I ask about sicca symptoms. So because those are usually pretty specific for Sjogren's. And for sicca symptoms, what I mean is dryness in the eyes and mouth, and typically it has to be quite severe. So, like for example, I have dry mouth, I have dry eyes. They're related to allergies, acid reflux, things like that, right? And it's very common for a lot of people to have that for common reasons. But I'm talking about like really severe dry eyes that even can cause eye redness, frequent tearing, even sometimes pain, dry mouth that can be painful, can lead to cavities. Um, and if all of that's negative, then I start to ask about less specific symptoms, things like arthritis, things like constitutional symptoms, oral ulcers, rashes, because I find that those symptoms, even though those are common rheumatologic diseases, are also very commonly mimicked, and so they're less specific. So those are the questions I'll be asking. And then in the chat, they're asking like, is this a high titer ANA? So this is definitely a high titer ANA. But still, even with a high titer ANA, it can still be a false positive. So I rely mostly on the clinical scenario and the chronicity rather than how high or how specific the ANA is. So yeah, I'm curious to what happens next.
Awesome. Thank you guys so much. So she still hasn't seen me yet, but she's now seeing a couple specialists. So I'll kind of walk you through sort of what happened here. So she got referred to GI for her symptoms. They actually decided to treat her for the cyclospora with Bactrim. She had previously been on azithromycin, which was unclear if it was helping from the urgent care. And immediately after she was on Bactrim, after dose 4, dose 5, she actually developed a rash with lip swelling and paresthesias. They thought it was maybe an allergic reaction. So she was stopped on that and given Benadryl, of course, a prednisone, some other things. So that was kind of happening. And then GI just told her, don't take any more, modify your diet. There was a talk about maybe doing an endoscopy or colonoscopy for her, but they felt like some of the histologic findings for other entities like tropical sprue would be similar. So they held off and the patient wasn't very keen on it. She does get referred to oncology because of the lymphadenopathy. So they do a very extensive review of systems for her. So she denied any fevers, any night sweats, any lymphadenopathy. She said she had been having some weight loss, not only from the Zepbound, but a lot because of the diarrhea, even after she had stopped it and she was having some fatigue. But otherwise, she said other than eczema, really nothing else on her review of systems at all. So they were kind of perplexed. They actually end up like you asked for Andrew, she ended up getting a pan scan, a CT chest, abdomen, pelvis. So I can tell you what they found in the chest. They found some lymphadenopathy. More specifically, they found this mild prominent left axillary lymph node that was 12 millimeters and a left subpectoral lymph node that was 10 millimeters. And then she had the stable retroperitoneal lymphadenopathy and the splenomegaly. And then she did not get any additional blood work at this point. So I'm going to just stop there and see what you guys think.
All right, interesting. So, since it is diffuse lymphadenopathy, and in a very confusing case like this, where this patient clearly still doesn't have an answer, is seeing multiple specialists, it's helpful to be systematic and rely on something as just a grounding point in clinical reasoning. So, I just use my I-made mnemonic for diffuse lymphadenopathy here because that's the mnemonic I use for diffuse lymphadenopathy. We borrow this from the fever with a little modification. So infections, we've already tested for a lot of the viral ones here. HIV, EBV, CMV are kind of the big ones to keep in mind, ignoring some of like the pediatric ones like measles and mumps. For bacteria, you want to consider a lot of those granulomatous culture negative sort of bacteria. So tuberculosis. I forget if we got a travel history on her, but we would be doing that if we hadn't gotten that.
No, no travel.
No travel. Okay, so unlikely, possible in the U.S., but less likely. Endemic fungi you consider for other granulomatous infections. So she's someone who kind of like goes outdoors and like hikes a lot. Any exposure to like recent construction sites that where histo could have been brought up and disturbed, things like that. For the culture negative stuff that can cause diffuse lymphadenopathy, pets are kind of important, particularly for Bartonella. We've had a lot of pet cases this past week, but that's on the checklist is seeing if she has any animal exposures recently. And then for parasitic stuff, definitely less common in the States. So actually, I don't even have a good list like off the top of my head for parasitic. Here, leishmaniasis. There we go. That's like pretty common worldwide, but like not very common in the U.S. So that's I. M is malignancy. So the only way to get an answer for that, if there's no suspicion for a solid tumor, because of course solid tumor can metastasize to lymph nodes. We're not seeing any solid tumors on our pan scan, so we're not talking about that. We're more talking about like primary liquid lymphomas. The only way to really get a true answer at that is going to be a biopsy of one of the lymph nodes to answer that question. The best way to diagnose lymphoma is with an excisional lymph node biopsy, because you can put a needle in and do something called an FNA, where you just basically take out the cells. But if you chop out and excise a whole lymph node, you can slice it in half and really look at the entire architecture of the lymph node. Jeffrey's actually an expert in that. He wrote a whole review on kind of how to distinguish malignancies from rheumatologic diseases, and he teaches about this. The TLDR, though, is you just want to be able to look at the whole lymph node architecture and see if it's distorted, as it usually is in lymphoma, and they look a particular way. So that would be the best way to get an answer for that. A is for autoimmune disease, which we already covered, so I won't go through that. We're just going to be doing the history and additional lab work, as Jeffrey said. D for modifications from the I made mnemonic. Drugs, I consider, is it a recurrent issue? Like serum sickness can actually do this. So I forget what the Dupixent story is and if Dupixent can cause this, but serum
Oh,
sickness with repetitive exposures is something to think about with lymphadenopathy. But the other kind of more subacute progressive syndromes are drug-induced vasculitis, which this patient isn't on anything that can cause that. And then what's the other one? Try not to look at my notes here, guys. Um, uh, all right, I'm gonna fall back on my notes for the second one because this is important. Dress. So yeah, anything that can cause dress syndrome or drug-induced hypersensitivity syndrome that can also cause this. We got the CBC that didn't look super funky. It sounds like the LFTs are okay. So there's no
yep.
strong kind
Very
of signal for that, and no kind of clear drug culprits for that too. And the last one in the mnemonic is E for exposure, and this is also kind of a fun list. So have they inhaled anything, or do they do any like occupational things that expose them to kind of fine dust particles where they would should be wearing a mask, but they're not wearing a mask? That can cause silicosis. Patients who have weird exposures to injections, like through IV drug use, can get some weird syndromes that cause diffuse lymphadenopathy. And finally, in exposure, I just put like reactive, like just a reactive to whatever, like elsewhere. And here, clearly, there's like nothing that this person's like really reactive to. So yeah, I think probably for next steps for me, Jeffrey, I would just be getting the filled in history on exposures because we still don't know about pets. We already got travel and we just got the drugs history. And then we can fill in infectious studies that make sense past that point. And then probably if that doesn't yield anything, we're looking at excisional lymph node biopsy. But what do you think?
Yeah, wow. That was a great overview of all the different causes of generalized lymphadenopathy. So, we still haven't had a rheumatologic review systems. Dr. Gupta hasn't saw this patient yet at this point. So, who knows? Like, the patient may start talking about like malar rash and Raynaud's and all that stuff, and we have a clear picture. But I guess I will comment on what it seems like before we have a rheumatologic history. So there's two. I'll basically give you two different things to go through. So the first is the rheumatologic causes of diffuse or generalized lymphadenopathy. So there are four major causes of rheumatologic diffuse lymphadenopathy. So the first one is diseases that are like connective tissue diseases. So basically lupus, Sjogren's, scleroderma, myositis, what we talked about. Those are associated with the positive ANA. Out of those two, the most common ones are lupus and Sjogren's. Seropositive RA, technically, I sometimes put in that category, but it has to be long-standing, uncontrolled seropositive RA to have generalized lymphadenopathy from it. So definitely would be because the ANA is positive. I guess that's the only signal I have right now. Would be definitely looking for symptoms for like lupus or Sjogren's. Um, Interestingly, we're not having any cervical lymphadenopathy. It's actually one of the most common things for Sjogren's is to have cervical lymphadenopathy, but we don't have that. And the reason is because most of the symptoms that you have in Sjogren's, like obstruction in the salivary gland area, you have reactive cervical lymphadenopathy there. So the other three main causes, so the next cause to consider is sarcoidosis. So it's very classic. This picture could be very classic for sarcoidosis, except for the one fact is that they don't have intrathoracic lymphadenopathy, which is there in like 90, I would say like 99% of patients with sarcoid. But otherwise, like an incidentally found diffuse lymphadenopathy with splenomegaly is a perfect story for sarcoid. And we can see if the lymph node biopsy eventually, if we do one, has non-casing granulomas. But I would be very hesitant to call this sarcoid, even if I saw granulomas, just because there's no pulmonary involvement. Now, you can have, in rare cases, sarcoid without the pulmonary involvement, which is best described in number one, cutaneous sarcoid, which is almost like cutaneous lupus. So I'm not really even sure you can would call that systemic sarcoid. Neurosarcoidosis can sometimes be tricky and you don't necessarily have involvement there. And then finally, in some cases, is kind of weird, but you can have like renal sarcoidosis. There's something called like Tinea syndrome, which is
Mm.
plus or minus, like, is this actually a sarcoidosis thing or not? So, sarcoidosis is number two. Number three is IgG4 disease. So, IgG4 disease, also like classic story, diffuse lymphadenopathy. Splenomegaly, though, is quite rare of a manifestation to incidentally find with IgG4. And the other really important thing to know is with IgG4 is that you can't, well, my approach is that if diffuse lymphadenopathy is the only thing that you have, you should almost never try your best to not diagnose them with IgG4 disease because a lot of diseases can have positive IgG4 in the lymph node biopsy and even in the serum that are just mildly reactive. For like one example is syphilis, right? Some infections can cause it, some cancers can cause it, even other rheumatologic diseases like lupus can cause it. So IgG4 is on there, but I'm going to put that off the table as well. The fourth thing, and so this is an important category, is autoinflammatory diseases. So specifically, adult onset Still's disease is what we most commonly see in adults, and she's adult presentation. This can cause diffuse lymphadenopathy splenomegaly very commonly, but it's usually not going to be indolent. It can start off indolent and be progressive, and eventually she comes in with a fever, and eventually she comes in with arthritis. But right now, without other details of does she have arthritis rash, I'm going to put less on the table, but it's going to be a really important one to keep in mind because there's no intrathoracic lymphadenopathy. And I said auto-inflammatory syndrome. So that includes like all of the periodic fever syndromes, both the ones we have genes for and the ones that we don't, as well as the inborn errors of immunity, right? So those are the four causes. And then over the non-rheumatologic causes. So Andrew basically kind of mentioned most of them, but I will try to tease apart which ones to focus on. Um, so I think from the viral causes, we said that HIV is probably the biggest one to make sure that this is not. So if this HIV that was sent was not a PCR, but it was an antibody, I would repeat it because it can take up to 6 weeks for seroconversion, especially with a history of cyclospora that maybe is worse than general. I feel like HIV would fit really well here. So that's one consideration. The other thing is HHV6, actually. HHV6 causes diffuse lymphadenopathy. It can be chronic, it can be indolent, it can have almost minimal symptoms. So that's another thing that we can test for. It can be very hard to think of or test for. But for the viral etiologies, I think those two make sense as the EBV and CMV or negative. From the bacterial side, so I think there are a couple of things. I think Andrew mentioned like granulomatous infections. So definitely like TB is like very well described to have this presentation of like indolent, like nothing's going on. PCP regular checkup shows like diffuse lymphadenopathy and splenomegaly. So I think definitely looking for tuberculosis makes sense. The thing that makes me uh, less concerned, I guess, for it is that there's no pulmonary involvement as well. So this would have to be like disseminated TB, essentially, that's extrapulmonary, and that can be very difficult to diagnose. But I feel like the absence of the lymphadenopathy, with mediastinal lymphadenopathy, also points me kind of away from TB and fungal infections. Although I'd be glad to learn if that's the case. And other important things in the bacterial side is syphilis is probably a really important one because you can have GI involvement with syphilis. Secondary syphilis specifically, so not primary or tertiary syphilis, but secondary syphilis presents with diffuse lymphadenopathy very commonly. And you can have some other in features, intestinal syphilis, it would be a rare feature of it, but possibly that's what was going on. Um, so that's something that, could be on the differential here. But the syphilis test was negative, and it should be positive by the time that you check it during secondary syphilis. Other infections here, tularemia is possible. If she had this, usually it's not a GI-like illness. It's more of a pneumonic or maybe upper respiratory illness. But tularemia, it's, the history that you would get is you have a fever syndrome. And then after the fever syndrome, which is maybe misdiagnosed as a flu or some type of infection, there's a second phase. And the second phase often has generalized peripheral lymphadenopathy. But the key is to follow it. And in usually, well, at least according to what I've read in the literature, if you keep following it, the lymph nodes will start to necrose and actually develop abscesses and become separative. So if that happens, that's a sign of tularemia. And then in terms of non-infectious causes, so lymphoproliferative causes, what could cause indolent lymphadenopathy? I think what we're dealing with here are indolent lymphomas and Castleman's disease, those two mainly. And I won't go over all the different causes of those right now. But I'll just let Akash tell us what happens next in this story.
Yeah, so actually, so again, this is before she sees me, so keep that in mind. So I think somebody had asked for a excisional lymph node biopsy. So they actually end up getting one for her. So where they go is they go in that right inguinal lymph node. And so they do flow studies on it, which don't show any overt evidence of lymphoma. And then let me see if there was anything else. Yeah, so literally all they did the first time was that was available to me was they just said it was negative for lymphoma. So they weren't happy with this. So her oncologist actually ordered a PET CT for the patient. And so on the PET CT, she had bilateral axillary external iliac inguinal adenopathy with moderate FDG activity and splenomegaly with increased FDG activity concerning for involvement. So she actually gets another lymph node biopsy, and they go to the left groin. And what they noted here was that the lymph node had partially preserved nodal architecture, follicles of varying size. The sinuses are mildly expanded by histiocytes. There's scattered neutrophils, rare eosinophils, no necrosis. And then they said there's so basically reactive interfollicular expansion. She's negative for lymphoma, negative for microorganisms by GMS and AFB special stains. And then the flow cytometry on this was negative. So she's had all this done. And then so I finally meet this patient kind of after all this massive workup has been done. So I meet her like literally 4 or 5 months later. So pertinence for you guys to know, she's had issues with fatigue and joint pains for 9 years. She said she used to be active playing soccer, so she attributed a lot to that. She actually works as a teacher, and now she does some work for the government. She had a lot of soccer injuries growing up, meniscal injuries. Then she had issues with weight gain because of her mood symptoms. Rashes, she reports, is she's just had what has been termed eczema for 9 years. And so she had actually never started the Dupixent when I talked to her. It had been documented in the notes, but she never actually started it at all. And then when I went back to talk to her more, she actually told me she has had lots of GI issues since high school, that she has lots of loose bowel movements. She would have some constipation. They did a workup for celiacs. It was maybe borderline positive, but she had a low IgA, so they were not really sure what to make of her symptoms. And then there was no fevers, no photosensitivity, um, has some dry eyes, but thinks it's from her contacts, no dry mouth. And then she just said that she has a little bit of deconditioning. And then when I saw her on her exam, other than her skin, where she had some scaling and xerosis and sign of lichenification on her hands and arms, there was really nothing else. So I'm going to stop there before I tell you guys the whole slew of labs I ordered and then what came back.
Wow, this is so interesting, Akash. I think it's worth digesting what happened with this
Yeah, sorry I went through
biopsy.
that quick.
Oh no, yeah, yeah, no, yeah, no worries. Yeah, I think it's worth going through kind of the PET-CT decision making and the lymph node biopsy because that happened very quickly, but that was like a very kind of systematic thing that they did next. So if you're worried about lymphoma and you do the excisional lymph node biopsy, which I said is the gold standard, but it's negative, you still don't have an answer. So if somebody is still worried about lymphoma, they're probably going to go for it again. Why that is some of these lymphomas tend to kind of jump from node to node. And when this happens and the initial biopsy is negative, they'll often get the PET-CT to look for a more avid region, which is supposed to be this idea of the more avid region is kind of where the malignancy is living at that moment of time, and kind of that's where you should go for the next excisional biopsy. So what they were really doing was kind of betting on that next lymph node being a better target. And it sounds like they got it, and the architecture was mostly preserved. So we could say that if we're again considering that this is a lymphoma, this was another bad target. But I think there's a lot of other interesting stuff going on in the history to kind of question that hypothesis. But what are the other pertinent things they did on the lymph node? The GMS stain was negative, so that's looking for fungus, really. So if you have an intact immune system and you have something like histoplasmosis, oftentimes you won't culture anything in a lymph node because your immune system's actually doing its job and it kills what's inside the lymph node. But you can still stain it with silver staining, like GMS staining, and you'll still highlight kind of the like carcasses of the fungus is how I think about it and how a pathologist taught me to think about it. So, with the GMS stain and with what Jeffrey was saying earlier about there being no pulmonary signature, I think it's unlikely that there's a diffuse fungal infection going on with that silver stain. The AFB culture being negative, we actually just had a case last week of AFB culture negative, but what is it, next gen sequence positive for TV. So by no means this doesn't rule it out, but I don't think the story here really fits with that. So I think we can kind of consider that's negative. But no, Jeffrey, I'm having flashbacks here to the case I presented you of a really acute GI syndrome in someone with a history of depression and whose compliments were sent very late in the course and were positive. I'm wondering if some of the features here could fit with like a more chronic indolent like lupus enteritis, and maybe next we need to start sending the complements and kind of the reflex panel for the ANA. That's where my mind went next, so I'll pass it off to you.
Yeah, this is what an amazing presentation so far. So I think really the challenge here is still like how do we focus and what is the problem representation? So I would say that this problem representation, it seems like now, is maybe recurrent GI illness in a patient with what appears to be chronic lymphadenopathy and splenomegaly with very minimal symptoms. So we have like a disease that causes indolent lymphadenopathy and splenomegaly, and then we also have these recurrent GI symptoms. And again, my first reflexes to say maybe these two things are not tied together. They tested for celiac, but her IgA was low. Maybe they needed to send an IgG, like transglutaminase antibody, endomysial antibody. Maybe the diarrhea is just like, some type of malabsorption, some intolerance to food. Um, and then in terms of what could still cause this indolent type of picture with a negative lymph node biopsy, or essentially you have a lymph node biopsy that has preserved or almost, so not preserved architecture, but it has reactive follicular hyperplasia is what it seemed like.
Yes.
Um, So I mean, I mentioned a lot of different diseases from a lymphoproliferative standpoint. So in terms of infections, I'm not seeing granulomas here. So I don't think that all those granulose infections that we talked about, histo, blasto, TB, even none of them would make sense here. I mean, Bartonella can sometimes initially cause reactive follicular hyperplasia, but then almost inevitably then causes necrosis, granulomas, and then in maybe like 10% of the cases, it has this like almost pathognomonic, like star-shaped micro abscess. So maybe Bartonella could still be on there, but it's, the time course has been a while now. And patient has no other features. I would think that, and plus, this would have to be disseminated Bartonella. So it would have to be like endocarditis, or the patient would have to be immunocompromised, such as with like HIV or some type of other reason. So I think infection essentially is pretty low on the table. I think the only one that still maybe remains in my mind is HHV6. Um, and then in terms of like lymphoproliferative disease, like which lymphomas can do that? So usually this is an indolent lymphoma. The reason it's indolent is because we don't have like B symptoms, fevers, right? So, and in that category, the three main causes are follicular lymphoma, mantle cell lymphoma, and marginal zone lymphoma. So, out of those three, the one that most commonly causes can look like reactive follicular hyperplasia is going to be follicular lymphoma. Hence why it can look like reactive follicular hyperplasia if you miss it. So that's definitely something to consider. Could this be follicular lymphoma? It can. I've seen cases where it can present basically asymptomatically. Generally speaking, they have some features, but the features may not be like constitutional symptoms. So like maybe this GI illness is actually follicular lymphoma there, affecting the GI tract, which I've seen before. Usually, I would expect with like I don't necessarily feel like mantle cell lymphoma or with marginal zone lymphoma that necessarily fits as well. Mantle cell lymphoma usually has a little bit more of cytopenias, which we don't really have a CBC here, but we can see that. And then for marginal zone lymphoma, like this splenomegaly is kind of weird for it. By the time that you have splenomegaly, if you have lymphadenopathy, you would have basically kind of a stage three or further of a lymphoma with marginal zone lymphoma. I would expect more symptoms, is what I would at least suspect. And splenic marginal zone lymphoma can definitely be indolent, but you would have massive splenomegaly without any lymphadenopathy. So I think that doesn't make sense here. So it'd have to be like a nodal, uh, maybe like a nodal marginal zone lymphoma. Hodgkin's lymphoma can also be indolent, but typically that's either stage one or two, classic or nodular lymphocyte predominant Hodgkin's lymphoma. We have bilateral involvement, and we don't have a history of it kind of going down. We actually have a skipping of the mediastinal lymph nodes, so I would say that this can't be classical Hodgkin's lymphoma, although I, would love to learn if this is what it is. I would say nodular lymphocyte predominant Hodgkin's lymphoma could be there, but again, like by the time you have splenomegaly, this has to be like class three, so I would expect you would have B symptoms at this point. So I'm really kind of struggling to figure out which kind of lymphoma this could be other than follicular lymphoma. That's probably the main one that I'd be thinking about here. So if I wanted to figure that out, I would just do another excisional biopsy and specifically ask them to do the stains to look for follicular lymphoma. T cell follicular lymphoma can be really, really hard to diagnose, and we have maybe some effacement of the architecture. So I'd ask them to send T cell receptor rearrangement genes as well, both in the serum
Hmm.
and in the flow. So that's something that they can do. But yeah, otherwise, I'm not completely sure where to go next.
No, thank you guys. That was awesome discussion. So I can tell you guys what I sent, and then actually when I got a result back, I got more history. So I sent lots of labs. We have an ENA panel here. So I checked for double-stranded DNA, which was negative. SSA, SSB was negative. Smith, RNP, both of those were negative. SCL70, Joe1 were negative. Because she had that rash, this diagnosis of eczema, and I wasn't really sure, I did send a myositis panel, which was negative on her. Rheumatoid factor, CCP were negative. Her complement, C3 was a little elevated at 158. Upper limit of normal VAR lab is 157, so take that for what you will. Her C4 was 14, which is normal on our lab. And then I sent a CRP. It was 2.85 mgs per deciliter. Upper limit of normal on ours is 0.85. And then I sent quantitative immunoglobulins on her. So these were all low. Her IgG was 511, lower limit of normal in our lab is 588. Her IgM was 39, um, lower limit of normal in our lab is 57. And then her IgA was 21. So lower limit of normal is 46 on our lab here. And then when I talked to her more, she actually told me that for the last several years, she would get several respiratory infections a year. She would at least get the flu, cold several times a year, and GI infections quite a bit, like 5 to 7 a year. So I'm gonna stop there and see what you guys think. Oh, and her UA, urine protein creatinine were normal.
Well, I get a full circle moment here because when I presented a case with Jeffrey that was a highly questionable case of GI lupus, Jeffrey taught me the ways in which you can have lupus with a negative ANA and was talking about how if you have hypogammaglobulinemia, such as from CVID, the tighter or the level of detection for ANA may not be reached in order to like detect it, and they could very well have like lupus with a negative ANA. That's pretty much the limit of my understanding of how lupus and CVID are kind of related. But I think it's worth mentioning that the low immunoglobulins make you think of CVID. I agree with Youssef in the chat that that probably explains why they were predisposed to the cyclospora symptoms and why they're having the repeat kind of mucosal infections like in the upper respiratory tract Akash just mentioned. But no, I'll just pass off to Jeffrey here because he's the master at CVID and how it interplays with autoimmune stuff. So I can't wait to learn more.
Okay. Wow. This is super interesting now because now we actually are completely changing our problem representation to a patient who has chronic lymphadenopathy and splenomegaly, but also has a history of recurrent infections. So, okay, yeah, I was just putting in the chat. I did forget actually, small lymphocytic lymphoma actually can present like with everything being normal, just lymphadenopathy incidentally found. But again, it's an incorrect age group. This is usually in the older individuals, similar to like CLL. And the important thing to know is that lymphomas can cause secondary immunodeficiency. So especially if you have a B cell lymphoma, you can have your immunoglobulins, IgG, IgM, IgA all down from a lymphoma. So that's why it's also important to keep that in mind. But it's relatively unlikely for an indolent lymphoma to present with recurrent infections. That's just not the clinical story that we get with lymphomas, right? If you think about all the patients that you've seen with lymphoma, you rarely get a history that they have recurrent infections. So clinically, this patient has some type of immunodeficiency. And then, people in the chat were talking about, and we were talking about with Andrew, could this be CVID? So technically, the answer is no, this can't be CVID because the immunoglobulin and IgG level is not low enough to necessarily meet criteria, like the classic criteria for CVID. And how do we move forward here? So actually, there are several recent papers that are really good about inborn errors of immunity. But we look at the type of infections that this patient have. So they have recurrent sinopulmonary infections and GI infections. So this is classic for CVID. But one of the other things is, the cyclospora infection that they have. So, interestingly, I don't know that much about cyclospora, but, my only knowledge of cyclospora is in patients with HIV. And interestingly, patients with HIV have T cell dysfunction. So T cell dysfunction can lead to a lot of different types of infections, but one of them can be increased or worsening GI infections like cyclospora. So I wonder if this patient has not just really a B cell immunodeficiency, but more of a T cell. And the reason that I kind of say it like that is because number one, the IgG, the immunoglobulins are low, but they're not low enough necessarily to meet the cutoff specifically for CVID. And the second is the type of infections. that we have, aren't necessarily completely explained by just B cell dysfunction. So, if we had more kind of like true infections with like Streptococcus pneumonia, true documented viral infections, maybe that would, with HSV, things like that, maybe that would make me change my mind about is this purely a B cell immunodeficiency? But I think, if I had a guess based off of this and trusting, Akasha's great, like exam in history, that I would suspect that this may more likely be a T cell, or something around with not just the B cells, but in addition to that. So at least T cell, or maybe even broader. So where I would go next to this is, could this patient have something called autoimmune lymphoproliferative syndrome? Because this actually fits very perfectly for that set of diseases. And actually, specifically, not just any autoimmune lymphoproliferative syndrome, but what we call autoimmune lymphoproliferative syndrome like CVID like immunodeficiency. So it's like in between the two. And the way that you would test for that is that you would get a flow cytometry and you would look specifically for double negative CD4, CD8 alpha beta subtype of T cells. So that's a specific type of T cells that you should, then when they're activated, they should go through this process of they're activated, and eventually, once the infection or once the problem is resolved, they get deactivated. And once they're deactivated, they turn off the CD4, CD8, but then they also should get killed. And in autoimmune lymphoproliferative syndrome, the problem is that these T cells don't get killed. They stay and they cause continued immune system activation, which leads to lymphadenopathy, splenomegaly, and a whole set of possible autoimmune disorders, including things that we're seeing here, like maybe some of this GI is actually enteropathy, right? So I would look for that on the flow, and if this is positive, then I would follow that up with next generation sequencing to see if we can find a monogenic disorder. So I'll go. I'll end with that.
Yeah, so right now she's getting all of this workup. She's actually seeing one of our immunodeficiency specialists here. So the working diagnosis in some of my discussions with the allergy immunologist here is kind of like Jeffrey alluded to. It's this lymphoproliferative like CVID like sort of spectrum for her. So some of the genetic things are in the workup here, but like Jeffrey alluded to, CVID like CVID is kind of the spectrum, and there is concern a lot for immunodeficiency here. I think she has had multiple bouts of strep throat, from more history that was gathered as well. She has had pneumonias even as well. Unclear what that is, but significant more infections than even what she told me. So
Gosh, do we have NGS on the station? Do you know if the flow
it's
showed?
the Invitae panel is pending for this
Okay.
patient, and I don't think we have NGS yet
Oh, okay.
on her.
And do you know if the flow showed positive double CD4, CD8, double negative alpha beta T cells?
So that I have the lymphocyte enumeration panel. So they said that her proportion of naive T cells is lower than expected, but she had normal distribution of T cells overall with mildly elevated percentage of double negative alpha beta T cells.
Wow, look at that. That's pretty much diagnostic for ALPS-like CVID-like syndrome, essentially. So, there are a couple of things. I mean, I know the NGS is pending, and I know Kirtan will love this discussion, but there are a couple of disorders that why do we need to send NGS in these patients? Is because it actually can help dictate treatment. So the two main diseases that it can help with are going to be CTLA-4 and LRBA deficiency. So those two genetic diseases can both cause this in-between type. One is autosomal dominant, the other is autosomal recessive. I can't remember which one is which, but they have very specific treatments that are developed only for that condition. And there's actually a whole host of other ones. So, we talked about the main causes of autoimmune lymphoproliferative syndrome, right? So those are like FAS ligand, FASD, and then CASP8, CASP10. But those you will not have low immunoglobulins, right? So that's why I'm saying it's unlikely to be that. However, like things like CTLA4, LRBA deficiency, I'm sure Kirtan can mention more, like those type of mutations. I think Pi3 kinase is also on there. Maybe CARD11, something like that. Those set of mutations cause this kind of in-between phenotype. And not all of them actually have treatments for it, but some of them have direct treatments in addition to just doing something like IVIG. Because right now, IVIG may help with the low immunoglobulins, but in addition to the IVIG, you may need something else that can help with the immunodeficiency to kind of prevent her from getting these recurrent infections. So, thank you so much for presenting this case. Andrew, any other final thoughts?
No, Akash brought it today after we got his MPA diagnosis last time. You got me today, Akash. But hey, that's why I'm here with Jeffrey. So thank you, Jeffrey, for discussing with me, and we'll see you next time, Akash. Thanks for coming.
Yeah, thanks, guys. Hope you enjoyed the case. All
Yeah, I enjoyed it a lot. Thank you so much for reading this case.
right,
Have a good
thanks,
night,
guys.
everybody.
Have a good one.
Jillian, I forgot that to do teaching points, but I guess while people are still on here, you can, if you if you are able to summarize that, we'll do it.
I can go just briefly, I guess, whatever is best.
Yeah, just something brief, I think, and then we can end it.
Okay, so I'll just summarize general approach to lymphadenopathy because we've got a lot of specifics here, but I think that might be useful. So, like, first step is to determine how diffuse the lymphadenopathy is. For diffuse lymphaden for isolated or regional lymphadenopathy, there's a more limited differential diagnosis, including like anatomical localized problems and also IgG4 related disease. But for diffuse lymphadenopathy, we can use a modified version of the I-Maiden mnemonic, where we start with infection. There are lots of different infectious causes of diffuse lymphadenopathy, but notably viral causes are HIV, HHV6 are important to look for, as well as like EBV, CMV, bacterial causes like TB, syphilis, and atypical causes like endemic mycoses or culture negative bacterial infections or parasites. For malignancy, we're thinking mostly if it's diffuse of like liquid malignancies like lymphoma or Castleman's. And then autoimmune diseases, we have like lupus, Sjogren's, sarcoid, IgG4 disease, or autoinflammatory conditions like adult onset Still's disease, periodic fever, or immune insufficiency as we saw here. And then we have drugs. D is for drugs. We have serum sickness and drug-induced vasculitis or DRESS. And then for exposures, we have occupational hazards, IV drug use, reactive. And for working up or reactive, sort of general reactive causes. And for working up these things, the best is, especially for malignancy, the best is to do an excisional lymph node biopsy. Um, yeah, so that's the general approach to lymphadenopathy that we got a very in-depth explanation of in this case.
Thanks so much, Jillian, and thanks everybody for joining. Nice seeing you guys. Have a good night.